Hi everyone. Please forgive me if I start coughing furiously. I'm recovering from the flu. So this project is funded by Sydney Catalyst and is a feasibility project, so on a very small scale compared to what we've just heard about, but with the idea that we would look at how we can improve the referral process for people with a potential lung cancer. I have no disclosures to make. So if you think in terms of what we know about lung cancer, it's the number one cause of cancer death. More than 80% of people are diagnosed with a late-stage disease when there's no chance of cure, and the survival rates for people for 5 years is less than 15%. However, if we could intervene earlier and pick up those people, given that there's no lung cancer screening program in Australia, but we could pick them up when they first had early symptoms, how well could we do in terms of improving their chances of being cured? So this is the WHO's overview of how they describe screening versus early diagnosis. So we're thinking very much here in terms of the early diagnosis of lung cancer. Our program has been underpinned by a model in terms of how we wanted to approach this. So the thing to focus on here, this model from Fiona Walter and John Emery, is around the process of early cancer diagnosis. And you look in the middle of the screen there in terms of intervals. We're thinking about the appraisal that a patient goes through in terms of when they have symptoms, their decision to seek help and to arrange to see a healthcare provider, through to that process then of going through appraisal, investigations, referrals and appointments for the diagnosis, and through to the scheduling and planning of treatments in pre-diagnosis. Oh, the slides are jumping. But that there'll be a whole range of contributing factors that will intervene on how those intervals, how people present for getting assistance, and they will be at the patient level, the provider level, and of course the disease level. I'm just going to skip that slide. So in terms of publications from our team, we've done a lot of background work over the last 5 years to identify what the evidence practice gaps are in lung cancer. We approached 3 lung cancer multidisciplinary teams across Sydney Catalyst, so a team working in Orange, a team at St Vincent's and a team at RPA. And we did some priority setting with them around those gaps. What did they consider were the most important or significant gaps? And where did they see that the greatest level of change could be implemented in their clinical practices? So just very briefly, those 7 gaps were around early diagnosis and treatment, making sure that there was no underutilisation of effective, oh gosh, this thing's on a timer that I don't know about, the underutilisation of effective treatments, curative treatments, the underutilisation of palliative treatments, a lack of referral to multidisciplinary teams, a lack of psychosocial support, and lack of referral to palliative care services. So our team worked with those 3 different groups, and very consistently the message came back that they saw where they could affect the greatest issue or change in their service was to address the early diagnosis of lung cancer. We also conducted qualitative interviews then with general practitioners to talk to them about what their issues were, and with patients about the barriers to getting patients referred into the system early when they first presented with symptoms. And resoundingly from those interviews with the 11 GPs that we talked to was the issue of not knowing where to refer to for lung cancer patients. That's probably driven by the fact that most GPs will see less than 1 case of lung cancer per year, and there aren't guidelines or a lot of evidence that GPs necessarily can access at the right time for them to think about where should I be referring this patient. So in terms of where our intervention sits then, when you're thinking about those intervals that I showed you in the model, we're right in the centre. The RoaDmaP feasibility study is about improving that diagnostic referral process. There have been a number of other small trials in lung cancer in Australia. So 2 of those up on the screen. John Emery's work around the ERCO trial, improving rural cancer outcomes, and the CHESS trial, which has been to look at encouraging people to recognise their signs and symptoms and to present earlier for a respiratory consultation. And then further back, public awareness campaigns like the ones that mentioned in the panel this morning, looking out for lung cancer that Cancer Institute have run. And then as you move across the screen to the right-hand side and you think about pre-treatment, there are another number of other interventions that you could pursue in this area, particularly around fast-track or rapid referral clinics, looking at navigator interventions, and then as you move towards treatment, MDT interventions. So our intervention is very clearly in the middle of that. So our aim was to develop a referral decision prompt that would support GPs in referring their patients with a suspicious lesion on a CT scan to a respiratory physician for a respiratory consultation. However, when we started to look at unpacking this issue and whether there any previous studies had been done, there's nothing in Australia, and we found only 1 or 2 studies, one in Spain and one in Ireland, where people had actually used the radiological consultation as the point at which to deliver an intervention. And we wanted to therefore make sure that it was feasible for us to think about the fact that probably about 90% of people with lung cancer will have a CT scan. So is this the ideal, the teachable moment at which we can pick up patients and think about then how they're going to get from that step of having their CT scan through to seeing the respiratory physician as quickly as possible. Okay, so in a nutshell, this is what the referral decision prompt looks like. It's got 5 elements. The first is the background about guidelines. What do the optimal care pathway guidelines say about lung cancer care? And it is that key time point that people should be referred to a specialist within 2 weeks. The next line is to give people the information about where the local respiratory physician is located and their contact details. The third element is a link to the Health Pathways site. The fourth element is a link to the Cancer Institute's Can Refer multidisciplinary team website, and then finally a link to patient information. So the idea behind this is that you give your general practitioners a range of different options for how they can find the right specialist for their patient to refer to. And this literally gets pasted into the bottom of the CT scan result. So the GP will see all of this information along with the the radiological report in what the CT scan says. So it's not a separate piece of information that's delivered later on. The GP will see this as all one continuous piece of information. So what we needed to do was actually recruit some radiologists who were willing to let us try this out. So you can see here from the phase 1 pilot flowchart that we had a component of the project where we had the radiologists reviewing and inserting the prompt into the patient's record. In order to be able to do that, we had to consent patients first. So we went through a process of actually seeking the patient's consent, making sure we included nothing about lung cancer in any of the documentation so as not to distress or alarm the patient in any way. But then if the patient actually did have a suspicious lesion, then that information would go back to the general practitioner, which you can see here in the green section. And then we followed up with the GP and said, tell us about your patient, what happened, did they actually end up with a lung cancer, and can we also consent you then to give us information about the key dates during their referral pathway. And we had then an extra step in the orange section of the slide there at the bottom to say we will go to each of the hospitals that those patients have been referred to see what treatment they have then had. So very briefly, the feasibility study is just as I've described in the slide. We did a process evaluation with GPs, radiologists and the practice staff to ask them about 10 items across whether they thought this intervention was feasible. And we also did a retrospective audit of chest CT scans in 2 of our sites to ask people, to ask the radiologists how many scans they were actually picking up for suspicious lesions so that we could get some baseline data about what to expect. So as I mentioned, we had 3 practices. Anyone presenting for a chest CT scan was eligible, and the radiologist included the suspicious findings according to the American College of Radiologists guidelines. So apologies that the print is quite small, but I'll just take you through it in essence. We had 445 patients across those 3 radiology practices presenting. We were able to give the forms to 400 people, and out of those, 293 people consented to take part, which meant we could access their medical records. Out of those people, 12 had a suspicious lesion. So you can see it's a very small proportion. Only 4% of those people that we consented actually had the lesion. For all of those, the referral decision prompt was included as part of their scan and was sent to their GP. So 12 GPs, it was actually 11 because 1 GP had referred 2 patients, received the prompt. 8 of those people ended up with a diagnosis of lung cancer. 2 of them had respiratory problems that were not lung cancer, 1 had lymphoma, and 1 we lost to follow-up. And then we collected patient data in the hospitals, and we asked the GPs to complete the information for us in terms of whether it had changed their practice. So you can see that just to go through this process of doing a feasibility study takes quite a lot of effort to get a very small number of patients. But what we feel are the main outcomes of doing this feasibility study is that firstly we've been able to show that the intervention is feasible, acceptable and appropriate to GPs. Radiologists are very, very happy to include it. As you can see from the quote there on screen, they consider, the radiologist, a number of whom we interviewed, said that this was definitely a good idea because it's a way of us being able to target those patients with that lesion and making sure that there's no reason why the GP can't get the patient in to see the specialist as quickly as possible, rather than having to wait a long time for that person to flow through the system. As you can appreciate, with only 8 lung cancer cases, we don't have enough GPs to actually test whether this has impacted on the timeliness of their referral practice. But when we looked at those 8 patients, 3/4 of them, 2/3 of them, 66%, actually saw the clinician within that 2-week time frame that had been stipulated. So again, small numbers, but at least it gives us an indication of, in comparison, thank you, to the usual 100 to 120 days that most people are waiting from the point where they first have suspicion through to starting treatment. We can target in on that small diagnostic interval window and actually try and reduce that period to something more manageable. So in terms of next steps, well, we think we now have the evidence to show that this low-cost intervention is feasible in terms of we can integrate it into existing radiology reports. We've got the baseline data that we need for designing a larger cluster randomised control trial. And we also have a lot of feedback from the radiologists to say if you were to use the lung RADS, which is the classification for suspicious nodules that's been used in the lung cancer screening trial in the US, that we could become even more precise in picking up the right group of patients who would receive the prompt. And we have 12 different radiology companies who are interested in rolling the project out across New South Wales, and a lot of work's been done in the intervening time at St Vincent's Hospital with looking at how to customise the RDP for their rapid referral clinic. In Liverpool, we have clinicians working on using it with the nurse coordinator model, and at RPA looking at ways how we can routinise this prompt for all of the patients who are seen at Alfred Imaging. So the next step, of course, then is funding. And just very briefly to acknowledge my co-investigators and particularly to say a big thank you to our clinical investigators in the radiology clinics who were willing to give this a go. So thank you very much.